Hi, my name's Hiten Mitha. I'm a superintendent pharmacist and a senior lecturer in prescribing and medicine safety at the University of Manchester. Just finished another work from home day, something that we're all getting really used to. And I've been reflecting on how the past few weeks have seen a huge shift in the way in which my both clinical and academic work has changed. And I wanted to share those thoughts about the academic side with you. And also, I thought it would be really nice if you guys could share your stories with us and maybe we can learn from each other. After all, this is exactly what the network was created for. So, on the 17th of March, the University of Manchester stopped all face to face teaching, and what is normally a really busy campus became completely silent. And although students weren't present, the learning couldn't stop. Now, I wouldn't say that we've gone through a complete revolution, but certainly we've seen a rapid evolution in the past 3 weeks at the University of Manchester with our teaching. So at Manchester Medical School, we used a flipped classroom model. So much of our material is already accessible online, meaning that this can be remotely accessed by students. But for flipped classroom to work, the online material needs to be followed up and consolidated with some face-to-face teaching as well. Aside from teaching materials, there are also many other things that we need to consider. Clinical placements, assessments, and even graduation as well amongst them. Now, there's very little that we can do about clinical placements. The third, fourth, and fifth year medical students, they were called away from their placements, and there's been no substitute for this, nor should they be, really. Students have volunteered where they feel that they could, but this hasn't been in a clinical capacity, so their learning has been limited. The graduation ceremony was also postponed, but in the UK, the new cohort of graduate or junior doctors, they're due to start in August, and the health service can't really afford for this to be delayed. But again, at Manchester, we're fortunate that our final year students are ahead of the curve as they face their final exams in January, with the majority of them passing them. What was left was portfolio work, which could be completed and assessed remotely, and clinical placement attendance and sign-off. Having made the decision to suspend face-to-face teaching, the next step was also that we need to make sure that the students are safe from any adverse health problems as possible. And we recommended that they all returned home rather than isolate in student residence. Now, at this point, many people would say that this is going to be a huge challenge, but for me, I'd rather frame this as an opportunity. In fact, I'd go as far as to say that this is the biggest opportunity that we've had in academia to bring learning into a format that suits the current generation of students. In silos, future and forward-thinking teaching has slowly been making ground, but the current situation has forced the hand of everyone to attain a level of technology-enhanced learning that should already be the norm. So, where appropriate, at Manchester, we've created lectures that have been recorded and they've been uploaded onto an online platform for students to access as if they were sat there in the lecture theatre. But this also means that they're able to revisit the same video as many times as they like to consolidate their learning and use it for revision purposes. We're also seeing this bigger shift towards formative assessments, so assessing the students' learning without a definitive pass or fail, but allowing them to obtain some feedback, which means that they can learn from their mistakes and grow their knowledge and skills without the pressure of trying to attain a certain pass mark. The situation has brought out the best in lecturers and administration staff. Over the past 4 weeks, I've seen collaboration that would normally take months to complete, and it's been done with enthusiasm and skill. I also personally feel that it has brought me closer to my students. I've engaged with them much more on a personal level. I used to think that I always facilitated their learning in a manner that suited them, but now I've found that delivering material for them to work on independently has brought out a character in the students that neither I nor they realised that was there, or at least not to this extent. They are really driven to learn and they want to problem solve by themselves rather than sit next to 300 of their peers listening to a single voice impart what knowledge they think that the students need to know. For situations where interaction is required, we've used a webinar service to conduct the seminar or the workshop. This has been paired with remote teaching tools such as Nearpod, where students are able to answer questions on their laptop, iPad, tablet, or even smartphone, and this goes directly to the lecturer, who can then assess a student's progression. Another positive has been that normally, once a student has left the seminar, there usually is little conversation between the lecturer and student, but I found that I've been actively seeking discussions with the students to follow up on work that they're doing and to check their understanding. Because of this, I found that my teaching and relationship with the students has become much more informal, which has resulted in more engagement from the students and also from myself. Now, this doesn't mean that everything is working like clockwork. As undergraduate medical students, there's nothing that can replace clinical placements, time on the wards or clinics, and experience talking to patients. This is something that we'll have to show patience for. Until it's safe, we can't allow students to be put in harm's way by asking them to attend clinical work. But as a backup, we're considering the use of expert patients during webinars. Now, this would mean that the employment of real patients that are willing to share their story and allow students to simulate a consultation regarding the patient's actual case presentation. Alternatively, the use of simulated patients, where we use actors that can play a case presentation created by lecturers. Of course, this is far from ideal, but it gives the opportunity for students to have conversations, and hopefully this is just a short-term solution. Currently, our biggest problem is with assessment. We run two types of summative assessment at Manchester. Firstly, a multi-choice question, and secondly, observed structural clinical examinations, so OSCE stations. We've made the decision to continue running these assessments, and you might ask how. The multiple choice exam is simple to address. We've created the assessment on an online platform on which we'll have a time slot for students to complete an open book assessment. The OSCE exam presents the obvious question of how students will undertake practical assessments when they can't be within 2 meters of someone under social distancing guidance, or without subjecting the student and the simulated patient to possible corona risk. We'll be conducting the OSCE stations using a webinar service, and we have chosen and created some scenarios that don't involve physical skills, such as things like abdominal exams. We won't be doing those, for example. Instead, we're going to be focusing on communication skills, description assessments, and also prescription review questions. Normally, we run an 8-station assessment, but this is also going to be reduced to 5 or maybe 6 stations. Again, this is far from an ideal scenario, but the student progression through the programme must be judged on their ability to showcase their learning. And we felt that it was necessary to take their reflective learning in the form of portfolio into consideration, alongside the practical and communication skills assessment, to ensure that the students are ready for the next stage of their degree. The challenge can be seen as looking to mirror current clinical practice. Most primary care family physicians are triaging patients and undertaking their consultations either over the phone or using web video services, with very few face-to-face consultations occurring. Going forward, future of healthcare will also look to incorporate technology to improve efficiency, and we should look to embrace the change that we are having to kind of hastily implement. This could be a little bit of a watershed moment in academia, where rather than using teaching methods that are a little bit archaic and outdated, we look to kind of not only keep up with clinical work, but surpass it in order to prepare the generation of healthcare workers that not only going to hit the ground running when they qualify, but redefine the way clinical work is actually undertaken. And amongst all this terrible news, I think it's important that we look to the silver lining, accept the situation that we're in, and focus on giving the students the best experience that we can, especially given the circumstances, as well as using this to form new methods of future education. Now, thank you for listening, and I hope you found this useful. As I said at the beginning, this could be a great opportunity to share some good practice and strive to get better together. So I look forward to hearing your conversations. Thank you again. Hope you're all well.